Hi, Jamie Davis, the Pod Medic here from the MedicCast and EMS Today 2015, and we want to thank everybody for checking us out here in the Physio Control podcast studio. And thanks to Physio Control for making it possible for us to be here and capturing some of these great interviews and segments from the conference speakers and attendees. So I have Dr. Jason McMullan here with us, and we're going to talk a little bit about traumatic brain injury. And before we get to that, though, just tell us a little bit about your background, who you are, and where you got started and where you are right now.
Sure. So I cut my teeth as a volunteer EMT outside Charlotte, North Carolina, almost 2 decades ago.
Wow.
Now. I was never smart enough to be a paramedic, so I went to medical school instead, but never lost that pre-hospital vibe. So I am now at University of Cincinnati. I'm part of the Office of the Medical Director for Cincinnati Fire and several other EMS agencies around the Cincinnati area, and I also oversee EMS research for the University of Cincinnati. And I got to tell you, TBI I'm very passionate about because it's the one thing that I fear most.
Really?
Yes.
So what? TBI you fear more than penetrating trauma, or
100%.
Crushed injury, or blast injuries? Why?
Absolutely. So if you look at the overall mortality from trauma, you're looking in the 1 to 5% range. If you look at the overall mortality between with trauma and TBI, 30%. And
Wow.
of the 70% who live, many of them are devastated in the prime of their life. And for me, I value my personal independence and able to attend to my activities of daily living. And suffering TBI, it might hurt that. The other thing, and this is what's frustrating to me professionally and why I really look at this from an education and from a research standpoint, is that for penetrating trauma, we can help you, right? Needle decompression, some permissive hypotension, we got you, right? We
Right.
take care of you. Crush injury, blast injury, we can put on tourniquets, we can treat compartment syndrome and hyperkalemia. What can we do for TBI?
I have no idea. I'm hoping you can tell me, because that's my next question is, what is there interventionally that we can do to manage any of that?
So as field providers, we can recognize and we can react and we can transport in the most expeditious fashion to the most appropriate facility. But we have no cure. There have been, there's one of my mentors, one of his favorite lines is that there is a graveyard full of neuroprotectant agents and treatments for TBI that have all failed in
Wow.
clinical trials. What can we do as medicine? Well, there's intensive neurocritical care, which can help you out, and there's obviously neurosurgeons who can take off part of your skull to help relieve some of the swelling and improve your recovery. But as far as in the field, can't do it.
Can't do it. And I'll put my nurse's cap on here, but prevention obviously would be the biggest key.
Oh,
and
sure.
EMS organizations should be an active participant in prevention programs because of the fact that once an injury occurs, there's very little that even can be done at the hospital to take care of that.
You're right, and from a pure public health perspective, seatbelt laws that are near universal, helmet laws that are not in every state, and I'll get on my soapbox. I don't know why. Right, but
I don't know why either.
Helmet saves lives, no matter if you're on a skateboard or a bicycle, a moped, a motorized wheelchair, or a motorcycle. Right, they help. So in car accidents and such, we can. But the biggest risk factors for TBI, I kind of refer to them as the T's. Right, testosterone, as we do stuff.
Yes.
Toothlessness, tattoos, the ever important tooth to tattoo ratio.
Oh my goodness.
And ETOH, right? Because there's nothing more predictive that a TBI is about to happen than the words, "Hold my beer, watch this." All right? So until we can put a helmet on every man between the ages of 13 and 55, prevention can only go so far.
Can only go so far. Well, and you're right. I think some of us in EMS have called that job security.
Yep.
If it wasn't for people like that, we wouldn't have anything to do on our afternoons. But on the other side of it is, it is a severe problem, and it is something that recognition is the key. So let's go back a step and say, how do we recognize? What are we looking for with traumatic brain injury?
Right. So I'm going to get back on a soapbox. Forever, like in every EMT class, some of my mentors and the wisest and brightest, I come out of the state of North Carolina, so you got to forgive me if I'm a little bit simple, right? Yep. However, we forever in all the classes, you hear about diagnosis based off of head CT, right? This is an epidural hematoma. This is subdural hematoma. Well, unless you're in Austin, Texas, or Cleveland, where they actually have CT scanners in the back of ambulances, we will never make those diagnoses. And instead, we're left with a GCS. Now, I can tell you that all too often, the GCS, when I ask for it from a report, and not me because I'm perfect when I'm a field provider, but people that I know, what's the GCS? And they go, oh, about 9. Not helpful, right? In fact, when you look at how the GCS was created, it was created for head-injured Scotsmen. It was done, it's supposed to be measured after initial stabilization or resuscitation, which is not us, and it was never meant to be summed. It was meant to simply be an objective rating scale of what the eyes are doing, the verbal is doing, the motor is doing. Okay. So we're left with an imperfect way of doing things, but GCS is the best that we have for now. More importantly, how I like to try to address this is to treat it as altered mental status in the setting of trauma. It's too long to say, so we'll just kind of say TBI. But you gotta remember, this person could still be hypoglycemic. They could still be postictal. They could still have had a cardiac arrest and a dysrhythmia, right? And there's multiple medical things that could have gone on that either caused or is a sequelae of the injury. So we got to treat the entire patient and not just focus on massive head wound Harry over here, right? But when we suspect it, you first got to step back and say, all right, this person is obtunded. Does their condition match the injury? We've all been on that low-speed car accident on the highway where the person's in cardiac arrest. And that's because their cardiac arrest happened before the accident, right? They're not dead. It's not a traumatic arrest. So you still have to have those thoughts. And then during your assessment, if you think they have TBI, treat it as potential TBI. Now, what's kind of heartbreaking is that it's 2015 now, right? 8 years ago, co-published in Pre-Hospital Emergency Care were the guidelines for pre-hospital TBI care by the Brain Trauma Foundation. Same rigorous guidelines, the same way that ACLS and PALS and everything else goes. We don't know them. In fact, when we kind of looked at regional protocols that had them, none of the 61 that we looked at did they actually follow all the protocols. Only 2 had at least 70% of the recommendations followed in there. And these are not big, fancy things, right? These are simple things like defining hypoxia and stating avoid it. So anything less than 90% is associated with worse outcomes. Avoid hypotension. If you avoid prophylactic hyperventilation. Now I remember when I was taught years ago, everyone got bagged down. No, because hyperventilation, for every drop that you have in your end-tidal CO2 is a 4% reduction in your cerebral blood flow. That means if I drop that end-tidal CO2 number by 5, I cut the blood flow to your brain by 20%. Now, if you're herniating, if your brain is being squeezed out of the bottom of your skull, I want to make those blood vessels smaller to keep third grade inside, right? But let's say that you're just postictal, right? Or that you've got a bad but not fatal head injury, and now I bag you way down. I'm essentially strangling you en route. That's no good. So we got to monitor what we do. And then there's some simple things, right? Use gravity as your friend. In the hospitals, we call head of bed elevation, right? Put the head above the heart, venous drainage, and that helps with your pressure, right? Now, the ideal is 30 degrees. On a backboard, that means the head of the bed is 3 feet high. That ain't going to happen. But throw a gear bag or your boots or a junior firefighter under the head of the backboard when it's on the stretcher and prop it up, right? Pay attention to your C-collar. If your C-collar is too tight, it may be protecting your spine, right? But it's certainly going to limit the blood outflow from your head. Make sure that it is appropriate fitting and not too tight. These are simple things that we can do today. And the other is to just recognize and then take them to a center that can take care of them. Anyone can take care of the person who's drunk and fell down and hit their head, right? Not everyone can take care of the person who has an expanding epidural hematoma and problems with intracranial pressure. So call your helicopter if that's your fastest way, or if it's not your fastest way, just boot scoot it on down to your trauma center where they can take care of the patient.
Great. Well, Jason, this is something we could probably talk about for a long period of time. And
I talked about it for 2 hours the other day.
But It something that all of us need to be more knowledgeable about. And like you said, there are protocols for treatment out there. We just need to adopt them and integrate them into our own systems.
Yep. So if you do nothing else, Google 2007 Brain Trauma Foundation guidelines. Make sure you pick the pre-hospital version and the in-hospital or the military version, and there's your template right there.
Right there. Great. Well, thank you very much for being on the show. Appreciate it.
All right, sir.
Thank you. Right. And I want to thank all of you for checking out this episode here from EMS Today 2015. I'm Jamie Davis, the Pod Medic from mediccast.tv. You can find all of the episodes from EMS Today over there, and of course over at emstoday.com.